request Dr. Jaspreet SUKHIJA, who is professor and chief of the pediatric and strabismus surgery at PGI Chandigarh. He will be speaking on intraocular lens implantation in children, when and where to place.
Good morning to all, and thank you, Professor Jagatram, who was my mentor, for having me in this instruction course. And of course, he's a legend in pediatric cataract surgery, and we've all learned from him. So I would be discussing something about intraocular lens implantation in children. It's been very nicely covered by the previous speakers, and a part of this when to implant, as has been discussed in the previous talk as well. So we'll just go a little further, have some videos, and maybe some other points for discussion where probably people till now would not have implanted an IOL. So what are the indications for IOL implantation in children? Of course, this is universal. When your axial length is more than 17 millimeters, you have a corneal diameter of 10 millimeters or more. This is based on biometry, but then you based on age as well. So there is basically a consensus that below 6 months of age do not implant an IOL. And of course, based on other biometric factors, even if the child is above 6 months, then of course demographics has a big role, especially in the context of India versus the Western countries. So where to implant the IOL? Conventionally, what do we do? As has been shown very nicely in the videos, it's endocapsular implantation. So you would basically try and implant the IOL in the bag. That's the place which has been, we've been used to, and that's been described in literature and well studied over the period of years. The other thing which has come up recently is the optic capture. So basically all these things are coming up to prevent visual axis obscuration. Sulcus cases, it's a big no. Very, very selected cases, maybe some older children. And of course, a bag in the lens, which is being done in Europe, and that's a patented IOL. We don't have that in India as well, and it's really working wonders. So what is routine pediatric cataract surgery? I mean, routine pediatric cataract surgery is doing a primary posterior capsulotomy, doing an anterior vitrectomy, and placing the IOL in the bag. So basically, you do stain the lens here, the capsule in children, because of you need to decrease the elasticity, you have to have a good visibility. So having a anterior capsular axis slightly smaller than the IOL optic is the optimal condition here. You can see the anterior capsular axis, which is about 5 to 5.5 millimeters, and then you can do a manual posterior capsulotomy. So basically, you can start off with the needle, and you have a better control when you use an Utrata forceps, what you are doing here. So you make it about 3.5 to 4 millimeters, because the IOL has to go in the bag. So it should not be much bigger, otherwise you might have the IOL going into the vitreous. So we stained here with the triamcinolone, done just to stain the vitreous, because you need to do the anterior vitrectomy. So once you've done an adequate anterior vitrectomy, that is the time when you see now you have a good nice anterior axis and a posterior axis. What you do next is basically implant the IOL in the bag. So when you're implanting the IOL in the bag, this is a 3-piece IOL what I'm using here. Don't try to dial the IOL that much. Just tap the trailing haptic into the bag, because we don't need to dial it with the posterior capsular axis. So just tap it inside the bag. So here what we have is now a nice fit IOL which is in the bag. So that's the routine cases what we would do. The other thing what you do is you could do vitrectorexis. So in such cases, when you know that the capsule is weak, I mean doing a manual vitrectorexis, doing a manual capsulotomy, a posterior capsulotomy, I mean, is difficult. So we place the IOL, and we're going behind the IOL and doing a vitrectorexis. So this is a safer procedure here in such conditions. So you have to see the morphology of the capsule before deciding what you want to do. Do a manual before it, or you would do a vitrectorexis after placing the IOL. So the IOL is in the bag. That is the ideal position. And after that, we've done the posterior capsulorexis with capsulotomy with the vitrectomy machine. So this is another one now. After the IOL in the bag, we moved on to what was described by Gimbal, I think, posterior optic capture. So in children, probably we did not have a large series, and we try to compare it here using in bilateral cataract. So in one patient, in one eye we did IOL in the bag, and the other eye, what we did was a posterior optic capture. So I'll just tell you what a posterior optic capture is. So in this is one of our cases here. Of course, we dilated it with the intracameral mid-atic. So I'll just go further and tell you. So after the anterior capsular axis, we are just removing the lens matter as we would do in a routine case. And once the important thing after removing the lens matter is the posterior capsulotomy. So the posterior capsulotomy has to be larger. One second. So the posterior capsulotomy has to be larger as you would do in a routine case of IOL implantation when you're intending it to put in the bag. So if you see here, it's a large posterior capsular axis. We haven't done an anterior vitrectomy here because we're going to place the IOL, the optic, in the Burgess space. So we put the IOL in the bag, and now we're going to gradually, you can say, just nudge it behind the posterior capsule. So the indication for a successful capture is that you have an oblong or a diamond-shaped posterior axis. You can see here the diamond-shaped posterior axis. This is the axis. So it's locked here at the optic-haptic junction. So you have the haptic in the bag, and the optic is gone behind the posterior capsule. So with that, what happens is there is going to be fibrosis along all the anterior and posterior capsule like a sommering ring here. So that's what we're going to achieve. This is what we achieved here. You can see here a very nice fibrosis occurring between the anterior and posterior capsule. Remember, no anterior vitrectomy was done here. Whereas in this eye, the anterior vitrectomy was done, the IOL is in the bag. You can see the anterior axis, the posterior axis, the IOL is in the bag. And after maybe a few years down the line, you have a nice sommering ring. There is no visual axis obscuration. So without an anterior vitrectomy, when you did the capture, there is no visual axis obscuration because everything is sequestered in the bag because it's sealed. The bag is sealed because there is nothing in the bag. The optic is behind the posterior capsule. And if you see here in the bag what's happening, there is lens matter proliferation, even though it has not reached the visual axis. So that is the advantage of doing a posterior optic capture. That's the second place where we can place the IOL. The third thing is, especially in cases of ophthalmos, when you have those bags which are large, and if you try to place an IOL in the bag, what really goes wrong is with a posterior capsulotomy, the IOL can just move about left and right, and you can have a decentered IOL. So in such cases, you can do an anterior capture. Anterior capture means the haptics are in the sulcus, and the optic goes in the bag, which is with the posterior capsulotomy. So I'm just going to end this video here by showing you that the indication for a good capture is, again, what you see is a diamond-shaped anterior rhexis. You can see this diamond-shaped anterior rhexis here. And post-op, you can see here the visual axis is clear. That's the posterior capsulotomy, this small circle. And you can see this diamond-shaped or the oblong anterior rhexis. So the haptics are in the sulcus, and the optic is in the bag. So this is another way you can place the IOL in cases where you have maybe large eyes. Now coming to something new which was been discussed in the previous presentation, what is the role of imaging in deciding IOL implantation? Earlier, what did we say? We said, fine, axial length more than 17, corneal diameter more than 10, or if the age is above 6 months, you can implant the IOL. But yes, there are cases where you can implant the IOL, where such agreement is not there. And also there are cases where such agreement is there and you might not be able to implant the IOL. So I'll show you two scenarios here. You have a 1.5-year child with an axial length of 21.5. So fairly good axial length. Corneal diameter is 10, but the cornea is steep. So the patient has a left eye PFV and a clear right lens. So the right lens is clear, and you can see here the cataract. This is a persistent fetal vasculature. Now if you see what the diameter of this capsular bag is from here to here, it's about 6.7 millimeters. So usually what you do is, it's about 8 millimeters when you can easily implant an IOL in the bag. Because your lens size, your bag is small, and the IOL is too big, so it will lead to tearing, and ultimately you'll have to get the IOL out. So what can you do in these cases? Well, what you can do is something this. Because it's unilateral, and in Indian condition, the contact lenses are a big issue. What you can do is something known as a bicapsular capture. So you have a good sulcus. So you put your haptics in the sulcus, what we've done here, and you get the optic behind the posterior capsule. So posterior optic capture was getting the haptics in the bag and the optic behind the posterior capsule. In bicapsular capture, it is your haptics in the sulcus and the optic is going behind the posterior capsule. So you can see here both the anterior and the posterior capsule are oblong. So that's the indication. And if you see here, you have a nice sommering ring here. you have few pigments on the IOL, which can happen in any child with surgery, and the visual axis is fairly clear. So we were able to rehabilitate this child in a unilateral case where otherwise it would have been difficult, or you would have complications had you tried to implant an IOL in the bag. So that is how imaging can help us. The other case, again, you have a 3-month child with an axial length of 18.2, fairly good. Corneal diameter is okay, 10 millimeters. Now, according to biometry, you can implant the IOL. But according to the bag diameter, you would avoid. So you can see the bag diameter. If had this been just based on the biometric values, we would have gone in for implanted an IOL with a good 18.2 and a diameter of 10 millimeters. But when you did the UBM, you can see it's hardly 6.2 in both the eyes. So that's the size of the capsular bag. So in such a small bag, you really don't want to implant an IOL because it will lead to complications. You'll have to take out the IOL. So that is how imaging is helping us. So this is another child, a 6-month-old child with bilateral cataract. Again, it was a UBM-based decision to leave the child aphakic, even though all these parameters were normal. You can see the corneal diameter is 10, fairly good. And basically, the axial length is 19.5 and 19.6, a fairly long eye. So basically here, had you not done this UBM, probably you would have gone and implanted the IOL because you have good corneal diameter and good biometry, and the child is 6 months. But when you did the UBM, you can see how small the bag is. It's just about maybe 6 millimeters, 5.7 to 6 millimeters in both the eyes. This is one eye, and this is the other eye. So this is the UBM measurements what we had, and this helped us to basically plan our IOL, and you can say leave the child aphakic rather than go and implant the IOL. This is just to show you the intraop OCT what we do, sometimes just to know the morphology of the lens, how it is, how the posterior capsule is, and whether it's membranous or white and all these things. We'll discuss, that's a later, that's for something later. So basically that's what was being discussed. That's what probably it will be published soon, this paper, which shows that how imaging is going to help us in the future when we have to decide for placing an intraocular lens in children. So basically, I'd like to conclude here by saying that primary IOL implantation is a good option when considering pediatric cataract surgery. It should be avoided in selected cases. Conventional placement of IOL in the bag has issues with visual axis opacification and secondary glaucoma. Refinements in techniques such as posterior optic capture have been shown to be better. Anterior optic capture stabilizes the IOLs in eyes with ophthalmos. Bag in the lens is a promising technique, but is limited by its availability. That's universal now, it's there in Europe only. And now what we are coming up is that UBM is a good imaging tool to support your planning. Thank you.
Thank you, Dr. Jaspreet, for excellent presentation. And you have told something new, that the particularly UBM, capsular bag size. Because till now we used to say that what is the axial length of the globe, what is the corneal diameter, and this is something new also, because many of the people, they are not considering the capsular bag size while implanting IOL. So thank